And now, shall we begin?
Yes, indeed. Let's begin. So after that intro, I hope you have an idea of what I'm going to talk about for the next while. It's not going to be an in-depth lecture on every component there, but I'm going to touch on some things that I think are quite interesting in the assessment and the management of the COVID patient. While I'm primarily going to be focusing on emergency department care, much of what I'm saying will apply equally to when we approach the patient in the ward or the ICU. So we're going to go through the typical emergency medicine ABCD approach initially, and then we'll get on to some of the other interesting areas. I have to say, I'm sure everyone is aware that there really isn't a lot of evidence in guiding us in how we deal with some of the issues with COVID. But where there is evidence, I'm going to highlight that and certainly highlight areas that perhaps you can read and get more detail if something catches your interest. I thought it was worthwhile, since we are talking about the approach to the COVID patient, that approach always needs to be with caution. And that caution in this case is for ourselves. And as much as possible, we need to make sure that we take care of ourselves whenever we come close to a COVID patient. We have to be humble enough to know that actually we don't know a lot about how COVID is transmitted. And there is talk that it may be much more aerosolized than we realize. The one day we'll see that people think that it's more transmitted by fomites, and the next by droplets and so on. So we do have to realize that we don't know exactly what we're doing with this, and so we need to approach with caution as much as possible. All right, so let's get onto the airway. And airway discussion in COVID, right from the beginning when we saw the first cases, has inspired quite a lot of interest in the discussion. And I'd like to highlight some of those points. As we go along, if you would like to type a question, I am monitoring the chat channel. So if you have a question, I will try and answer it as I'm going through the section. If there are too many, then we'll have to deal with them at the end. So what about the airway? What's quite important is we have to unlearn some of the things that we know about airway management. And in particular, one of them is the indications for intubation in COVID patients. And so we know classically that if a patient is obtunded or if they are nearing unconsciousness, that we need to intubate them to protect their airway. Well, some of the evidence, even before COVID, was that in fact, we probably don't need to be in much of a hurry to intubate purely for airway protection. And certainly in the COVID era, patients may be obtunded because of retention of carbon dioxide. We also know that that COVID patients who intubated do worse. And part of that is because they are just sicker, but part of it also is ventilation doesn't agree with the COVID lung. And so we do need to rethink and relook at these aspects. So if you see a patient who's obtunded, not because of hypoxia, or even if it is mild hypoxia, but because of raised CO2 levels, then we should consider other aspects of treating them before we consider intubation. So we're not rushing to intubation in these patients. And so this is the opportunity for doing things like non-invasive ventilation. In the hypercapnic patient, that's probably a better option than high-flow nasal cannula, at least initially. And then we can observe the patient and see, and if they improve, then we will have saved the patient the intubation, certainly at least for them. And often these patients do respond very well to non-invasive ventilation, and we can keep them on it and maintain both oxygenation and ventilation using that. And I know that there is subsequent lectures in the next few days on non-invasive ventilation and high-flow nasal oxygenation, which we will see a little bit later. At the beginning of COVID, there was a lot of discussion about elective intubations, to intubate when you thought the patient was going to get worse. And now very much we're against that again. we know that patients do better if we use other modalities to treat them rather than intubation and ventilation. And so it's very important to be aware of a change in indications in airway management in these patients. There's been a lot of interest across the world and in South Africa about the use of devices to protect people who are performing intubations. And this is an example of the aerosol box. The local version is called the Intubox. And interestingly, although the first few studies showed that it did maintain droplets or contained the spread of droplets, some of the subsequent studies have now shown that it makes intubation more difficult. It makes intubation take longer. And it also, in fact, some of the latest work shows that it can direct aerosols towards the intubator. And if the armholes are large and open, then in fact it can.
Sorry, Mike, are you still there? I think someone accidentally muted you.
All right, can you hear me now?
Yeah, I can.
Okay. I don't know where you lost me, but I will carry on saying that some of the latest evidence on the aerosol box is that it may in fact increase the exposure of the healthcare workers to aerosols. And it opens a very interesting aspect in evidence-based medicine, especially during times like the pandemic, where we are very desperate for evidence. And that's, it's great to come up with ideas, and ideas are essential to develop evidence. But we also have to be careful about not moving towards new treatments until there's evidence to support them. And we've seen this, and I think we've all been guilty to some degree of, you know, seesawing between hydroxychloroquine, and we were interested in that when some of the first studies came out. We're guilty of it with dexamethasone as well, where there's really only one study that's come out to show benefit. And so we do have to bear in mind that we must still be very critical of evidence that comes out, because while something might be a very good idea, it may end up, in fact, being harmful. And so it's important that that we really hold fast to evidence-based medicine in order to progress new ideas and their validation as much as possible. I think the other thing that's really important in airway management is the concept of the airway hero or the superhero. And I think because COVID patients are difficult in the sense that they desaturate really quickly, and because of the enthusiasm to do the procedure quickly and smoothly, it's always best to get the best possible person available to do the intubation. Now, this might be an anaesthetist, but it might not. Sometimes anaesthetists are uncomfortable working out of their own environment, and doing an intubation in the emergency department or the ward or the ICU might in fact be more the territory of people who are accustomed to working in those environments. And so whoever it is, ideally the best person should be employed to perform the intubation. And one of the saying, ultrasound in the beginning, in the front, the stethoscope at the back. The stethoscope is going to get a big across it, because we need to be careful about using a stethoscope in the emergency department or in any environment where we can't, if we're not sure whether the stethoscope is going to be sterile. It also means getting close to patients, and we do need to consider whether there are other options that we might need to use. Auscultation certainly can be safe, particularly if we do it from behind the patient. But if we are going to be using other imaging, like chest x-rays, then that's important. Also peeking out from behind the ultrasound is the pulse oximeter. And when assessing breathing, that's probably one of the most useful things for us. And in many areas, in many parts of the world, they're sending patients home with pulse oximeters, because we know that if someone has good saturations and isn't distressed, then it's likely that they don't have a severe pneumonia or COVID pneumonia that requires admission. Imaging using chest x-rays is actually not great. We know we miss a lot of things. Patients can actually have very bad pneumonias without it showing up on x-ray. And that's why the best imaging of the chest is either CT if it's indicated for another reason, or ultrasound. And I'd really encourage those who are familiar with some of the principles of ultrasound to use the ultrasound to image the chest in these patients. We know that patients with COVID often develop posterior pneumonias, and these can be really well seen with ultrasound. And there are some fairly typical changes that I'm hoping I'll show you after this slide. Peeking out from behind the screen again is the D-dimer. Now, D-dimer is a very interesting test. In the past, we've always hated it because the D-dimer is a very non-specific test. It can be positive if you sneeze too hard. It can be positive if you have a minor traumatic injury. There are many, many things that can make the D-dimer positive. But in fact, and COVID is one of them, and COVID makes the D-dimer go up very readily. But there's a very nice new evidence emerging that D-dimer may be one of our best methods of assessing the severity of patients with COVID. We know that really high levels of D-dimers are associated with poor outcomes. We know that really low levels of D-dimer on presentation and on day 3 are associated with really good outcomes. And so we can use the D-dimer to help us in that respect as well. One of the problems, of course, with D-dimer is that traditionally we use it for pulmonary embolism. And we know that pulmonary embolism is very common in patients with COVID. COVID, for some reason, causes an increase in coagulability, and we can see both peripheral and central thromboses, both arterial and venous. And if a patient has COVID, the D-dimer may be up because of pulmonary embolism, or may be up simply because of the sepsis. And this does mean that we're probably going to need to investigate more patients than we would expect for pulmonary embolism. It's very hard with a patient with a D-dimer of 6 to say, and who's very breathless, to say that it's only the pneumonia and there's no pulmonary embolism. And so that is a bit of a diagnostic problem. And so if we're not sure, then we need to commit to imaging with CT pulmonary angiograms or whatever is appropriate for the particular patient that you're seeing. But don't forget ultrasound. It is a pretty useful skill.
Could you try again?
I'm not sure how the arrow ended up on my screen. It wasn't me, but whoever put that on, if they could clear it, that would be great. Thank you. This is a view of what you might get with ultrasound in a patient with COVID. And these are B lines, these white lines that shoot down. B lines are fairly non-specific and merely indicates an increase in extravascular lung water. And so these the B lines, one might see with pulmonary edema, one might see with bacterial pneumonia, one might see with lung contusions, and also with other conditions like interstitial lung disease. So these are pretty non-specific. But as the COVID pneumonia advances, we see changes to the pleural line indicated with the arrows there. We see thickening of the pleura. One of the doyens of lung ultrasound, a guy called Volpicelli from Italy, hates the term thickening of the pleura. But unfortunately, that's exactly what it looks like. And it's a very good way to describe it. We see this pleural irregularity and pleural thickening. And this is very typical of COVID. And if you see a patient with that sort of feature on the pleuris, and not a thin line, but this area of thickening, that's highly suggestive of COVID. This you need the eye of someone who's done a few of these to see, but what this is indicating is a subpleural consolidation. Subpleural consolidations are typical of viral pneumonias. We learnt about them quite a lot when we had the H1N1 epidemic, and we saw these subpleural consolidations. Interesting, with influenza pneumonia, the pleural changes, the pleural thickening, we don't see. And so that seems to be a reasonably typical of COVID. So I would recommend lung ultrasound as a very good way of assessing patients and assessing the severity of pneumonia, and can help us to decide whether a patient can go home or whether a patient should be admitted into the hospital. It's not great for that, because we know that some people who are completely asymptomatic can have changes, both in whatever form of imaging you consider, but it is one of the factors that you can use to help you. If you don't think remember anything else from tonight's talk, I would suggest that you learn about this and about awake proning. This, I think, may well persist long after COVID in our initial management of patients with respiratory distress. And we know that patients with severe COVID pneumonias who may be saturating in the 60s when they're supine, they're put prone, can easily saturate in the 90s. And this is all related to VQ mismatch and where the lung is oxygenating. And if you put a patient to prone, the VQ mismatch will reduce and we will improve the oxygenation. And this is often sufficient to keep patients, prevent them from being intubated. They may then tolerate simple techniques like nasal prong oxygen or non-rebreather mask oxygen. So put a patient prone, then rotate them into right lateral recumbent, sitting, lateral recumbent, prone. And although you may think it's really uncomfortable for the patient, they love it because their breathing feels so much better with this. It is a little bit more limited in really large patients. And we know that if we're proning ventilated patients, there is a size limit that we can do it. But you can try it in large patients in the ED if they're breathing spontaneously, because if they don't cope, they will tell you, and it'll be very easy to get them back. So please, if you don't remember anything else, remember this awake proning as a very, very good technique. And sometimes people have described cases where if you are considering intubation, you can pre-oxygenate the patient by putting them prone. And people have described cases where they do this and in fact decide they don't need to intubate the patient because the oxygenation is so much improved. My wife, Professor Goldstein, came up with this idea of describing it like a rotisserie. And that's really what it is. What we're doing with the patients is we are slowly rotating them for 30 to 60 minutes at a time in various positions so that they don't get bed sores and they don't become too uncomfortable. And if you think of the rotisserie, that's a pretty good way to manage your patients in terms of the proning. You are going to get a talk in the next few days on high flow nasal oxygen. One of the big things to remember about it is that this isn't an aerosol generating procedure. But if you have a negative pressure area, or if you're going to be managing a patient in a red zone where there are other COVID patients, then it's reasonable to do it. And I think certainly there's clear evidence that using techniques like this on COVID patients is far better than invasive ventilation. If you don't know much about high flow nasal oxygen, I'm not going to spoil the thunder of the presentation in a few days, other than to tell you it's actually really interesting, the physiology behind how this works. And it probably works in a different way to how you may suspect, in that it's not related so much to PEEP as it is to reducing anatomical dead space. However it works though, it works really well. And I would strongly encourage those of you who are in the emergency department or in the ward who may need to use this to familiarize yourself with the equipment that's needed for this. Another option is non-invasive ventilation using a mask. In the past, we would say, well, we can only do this for 24 hours. So we would restrict its use to patients who we expect to improve in that period of time. So patients with pulmonary edema from renal failure or heart failure or something like that. But now people have been managed for prolonged periods of time with non-invasive mask ventilation and very successfully. Although it is also aerosol generating, it's probably a little bit less so than the high flow nasal oxygen. But this is very definitely something that everyone should be familiar with. I've also seen that some of the hospitals now have the Vigon system, CPAP system, which is just a purely oxygen-driven CPAP system. One of the concerns with that is that it uses extremely high flow rates of oxygen. And if you have many patients that you need to oxygenate, then you may run into troubles with oxygen flows. So that probably should be reserved for if you have no other options. Nonetheless, it is something useful. If you haven't seen it, it's a very bright green Busenac Vigon system and is one of the options that can be used. It's also a good pre-hospital technique. And then, of course, there is the helmet CPAP system, which is, of all the systems, probably the most comfortable for the patient. There aren't many available in South Africa at the moment. Some of the systems coming out of Europe can be 2,000 euros for the helmet, and so it's desperately expensive. But it is a system, and it's one of the systems that we're working on, looking to create a low-cost option for this. And we probably can get away with one that will cost 100 or 200 rand, but that's research in progress, and again, research that will need to be validated. But please be familiar with these. If you're working in the ED, they will be essential. Okay, so just some of the questions. What are acceptable SATS levels at home, and when should the patient come to hospital? That's a really good question from Jolene. And I'm not sure I know the answer to that. We are uncomfortable. I am going to talk a little bit about risk stratification when we get to the end. So maybe I'll talk about that then. I think it will make a little bit more sense. Another question, if a D-dimer level goes down from 32 to 0.33 in 2 days, is that considered lab fault? I'm not a lab expert, but that's really high, and I would think that there's a high chance that that's a lab error. I personally have never seen a change that dramatic, although others may have. Okay, so let's talk about the circulation. Assessment of circulation primarily must be from vital signs. And the vital signs are there as you see them. The brain is really important because a patient's level of consciousness often gives us an idea of their level of perfusion. Clearly, there are many things that can affect the brain, and we've talked about hypercapnia as one of them. But if a patient is hypoperfusing, then they may well be confused as well. Interestingly, one of the things that we should think about, which we don't normally do with non-invasive ventilation, is if a patient is passively uncooperative, we can use it. If they're actively uncooperative, we can actually consider sedation under those circumstances, knowing that if sedation fails, we may need to proceed to intubation. But it is, again, it's changing the rules a little bit of how we used to think about some of these things. With regards to assessing circulation, blood pressure is always a useless measurement, and it should always bring a bit of a second thought whether the blood pressure is high or low about what it means. But heart rate is a very important sign. And we know that patients who have a low heart rate are unlikely to have significant hemodynamic compromise unless they're really old or they're on medications that may affect that. But always the first step in assessing the circulation is look at the vital signs and evaluate the peripheral perfusion using capillary refill, and that will give you a really good idea about what's going on. It's also important to look at the blood gas, and this is not a blood gas from a COVID patient, but the blood gas gives us a lot of information. Obviously, in terms of respiratory assessment, we can see what's happening with the CO2 level. It's very seldom necessary to get an arterial gas initially, because the oxygen saturation via the pulse oximeter will give us most of the information. But here we want to look at the lactate and the base deficit, and that will give us an idea of the patient's circulatory status. A recent study in Britain looked at about 70 different hospitals across the world, and they took 1,200 patients and who were admitted with COVID, and they looked at those patients and they echoed each one of them. And they found that 50% of those patients had abnormalities on echo in one form or another. And of the patients where they found abnormalities, they had a change in management in a third of them. So using echo, if you have the skill, is a useful adjunct to guide you. What we're looking at here is a patient, this is an apical four-chamber view with a large dilated right ventricle with a McConnell sign. And this is a little pulling in at the apex of the right ventricle. And this was characteristic of two conditions. One is right ventricular infarct, and the other is a pulmonary embolism, a significant pulmonary embolism. And so that patient with a high D dimer who's breathless, if you put the probe on the patient and you see this, then that certainly gives you guidance that they have a pulmonary embolism that needs urgent management. One of the other interesting things that we're seeing, obviously, is lots of myocarditis, mild pericarditis, and causing systolic dysfunction in patients. On the left, we've got the apical four-chamber view, and on the right, parasternal long axis view. And you can see, if you look at the left ventricle, it's just really not contracting as well as you might expect. And certainly here, it's pretty obvious as well. We know that myocardial infarcts, both with and without coronary artery occlusions, are common in COVID, but also this picture is, there's patients with myocarditis. And a patient who's hypotensive, we know that if we give too much fluid, we're going to exacerbate the lung problems. So again, putting the probe on the patient, seeing that there's poor left ventricular function can assist us in deciding to start inotropic therapy earlier. The choice of the inotrope will depend on the patient's other hemodynamic factors, but certainly it gives us a guide that we need to start something fairly early. When we come to talking about prognosticating for patients, one of the good factors that has been described is using right ventricular dilation. And we can see this is an apical four-chamber view with a very large, poorly contracting right ventricle. This is the right ventricle here, with high pressure is causing a D shape of the left ventricle. So this enlargement of the right ventricle and right atrium is a poor prognostic feature. And so if you have an elderly patient with a severe pneumonia with this picture, and you're short of ICU beds, this is the sort of patient that is then just one of the factors that can help you decide where to send them. Fluids, be careful. Flood the patient, flood the lungs is going to make life much worse. And so you need to know, and echo is one of the few ways of helping you to decide whether to use inotropes or fluid. Most patients need a little bit of fluid, but we really do need to try and stay away from too much fluid. Okay, so that's D, disability or neurological assessment. I really only want to talk about a couple of things here. I think COVID is fascinating in how it affects the neurological system. We see patients with anosmia, patients unable to taste. That tells us something's happening neurologically and we don't understand it. But what we've also seen is a lot of young patients with strokes, and we've seen older patients presenting with strokes as well. So it comes to biases, and we'll talk a little bit more about that later. Is a patient with a stroke these days must be considered as a COVID stroke until proven otherwise. It doesn't change the management of the patient with a stroke, but it does mean that we need to be much more aware of these types of patients. The other type of patient to be very aware of is the patient who appears delirious or demented, because confusion is another very important part of the COVID differential. And so you may have a patient at any age presenting delirious, and it may simply be from COVID. And again, these patients need to be treated in a fairly straightforward fashion. But don't forget, these are the patients that catch us out, who may have COVID, and we may see a stroke on MRI and decide that this patient is a simple stroke, and that can lead us awry. Okay, ABCDE is environmental management. I talked a little bit about some of the aspects of this. We need to be aware when we're using devices like nebulizers that we try not to use those initially because they're aerosol generating. And we need to be aware of all aerosol generating procedures, that staff members who are around patients with that must be in full PPE with N95 or better PPE. There are options or alternatives to nebulizers using multi-dose inhalers and so on, with spacers or without spacers. So there certainly are options. I think we might all want to dress up like this on occasion when we are dealing with some of these patients. But whatever PPE that we use, it's important that we use it consistently and well. The other thing with environmental management is, like most of human factors, human factors are the most important. And we cannot carry on with life as normal in the same way that we're treating our patients differently to how we were some time ago. We need to make sure our own behavior is safe, and that we don't congregate and do things that might be harmful to us or to others. I see there's a question, is there benefit to prone positioning in the pre-hospital environment? Absolutely. Prone positioning, I think, is absolutely fabulous idea. Patients are doing it at home. And I really do think that if it saves an intubation pre-hospital, it's a really good idea. And I think it's probably very useful for patient comfort as well. I'm not aware of any research in this, and that would be really great to see, but I don't see many downsides from that. Okay, so let's move on to risk stratification in the last 15 or so minutes. Now, risk stratification is, what do we do with this patient? Is it safe to send them home? Do we have to admit them? If so, where? And how do we base our decisions on this? And unfortunately, there is almost zero evidence to guide this. We know that there are some types of patients who do badly, but how to actually put that together in a proper scoring system hasn't yet been achieved. But let's look at some of the things that we must consider. So we know the types of patients who do badly. And certainly age is one of the factors. It's very difficult to know a cutoff of at what age you go from being at low risk to being at high risk. And certainly as the older you get, the higher your risk of doing badly. But most people seem to regard 65 as a cutoff. And I'm not sure if it's real, but that's what is being used. So if you're more than 65 years of age, you are at much higher risk of severe disease and the need for in-hospital treatment. Something that has been obvious to us in treating patients is most of our severe pneumonias that we've seen have been in really fat people. Some of the initial guidelines suggested that a BMI of more than 40 was a risk factor. And that's certainly now subsequent evidence has shown that a BMI more than 30 is a very definite risk factor for severe disease. I know that there is some speculation as to the mechanism for this, but it certainly hasn't been clarified yet. And then we know chronic patients with comorbidities, and in particular, diabetes and cardiovascular diseases, and most commonly, of course, hypertension and ischemic heart disease. So if we see patients, you know, and an 85-year-old morbidly obese patient on multiple medications, we know that their risk is very high. Similarly, if we see a very young person who is fit and healthy, their risk is low. But we've all seen old, fat, sickly patients do well, and the odd young patient do poorly. So the decisions,
I'm not sure I understand.
Our decisions also need to be guided by patient's vital signs. And this includes things like saturations and heart rate, in addition to an assessment of the work of breathing and the respiratory rate. So clearly a young patient with none of those other factors, who's got a low heart rate, is saturating at 97, and has COVID, even if their COVID changes on lung imaging, is almost certainly safe to send home to evaluate at home. The problem is, of course, there's evidence lacking on the natural history of this disease and how to predict which patients do badly. And so we kind of have to best guess at this stage and tell patients to come in if they feel worse. At the other end of the spectrum, the patient with the admission saturations of 65, a heart rate of 120, that patient, irrespective of the other risk factors, clearly needs to be admitted. Their response to treatment is going to be important. So a youngish patient with the low SATs and tachycardia, who does very well on high-flow nasal oxygen, then can perhaps be sent to the ward rather than to the ICU, because we should probably only have patients in the ICU who need invasive ventilation and probably active hemodynamic management. But here we do have then the missing middle. We know it's easy to see the really sick patients. It's easy to see the really well patients. But, you know, the elderly diabetic who's got SATs of 92 and a heart rate of 90, what do we do with them? Do we keep them in hospital? Do we send them home? Well, at this point in the pandemic, it's really difficult to admit all those patients. Patients who have the resources can buy the pulse oximeter, the finger pulse oximeters, to monitor at home and to come in if the saturations are falling or if the breathing becomes more difficult. But we probably do need to send most of those patients who don't clearly need admission home to be watched at home. It's a very difficult ethical consideration because many of those patients we will be a little uncomfortable at sending home. But we also know that we probably are going to run to a point where we can only admit patients who actually actively need oxygen. And so we do need to, in our own environments, also think of ways that we can improve the early detection at home of when patients are deteriorating. Comment there is, someone says, discovery covers for an oximeter. And I would advise that for patients who you're not convinced are not going to deteriorate. And they can monitor with oximeter several times a day. And if the SATs are falling, and certainly if they go below 90, then they should be encouraged to come back into hospital. Okay, so who can we discharge? Well, we've talked a bit about that. And certainly there are some patients that's obvious that they can be discharged, and some that we actually can't really admit, and so we'll discharge reluctantly, but with lots of explanation to the patient. This is where I feel that telemedicine has a real role for us in the coming months, in that these patients, we can, once we've seen them in the emergency department or the rooms or whatever, we can then follow them up via teleconsultation every day or every second day if necessary. And there are some really clever ways of assessing a patient and assessing their breathing, even via teleconsult. And there are some described techniques for assessing saturations using counting techniques that you can do via telehealth. So as I said, some patients are easy to decide, we are more reluctant, but we probably really should only be admitting patients that we are fairly sure are going to deteriorate, patients who have lots of poor prognostic features, or patients who need oxygen. And the patient with SATs of 65 who responds well to oxygen therapy in whatever form it might be, can do really well in the ward. And so the initial saturation doesn't have to scare you that every patient like that needs ICU. Some of the evidence from the early days of COVID, just a month or two ago, suggests that most patients, in fact, who present to the emergency department will do well with initial oxygen therapy and may only a few days later decompensate and need escalation of therapy. So most of the patients we see will be appropriate to be put into the ward. There are a couple of scoring systems which just put patients at low, medium, or high risk. The problem with them is that they're just lists. So it'll be a list of comorbidities or a list of features and say, well, these patients are more likely to have moderate or severe disease, but it actually doesn't really guide how we provide this care. And so it's important that we learn as we go along and be prepared to reevaluate patients fairly frequently, as that is likely how we're going to prevent disasters. Intensive care, again, it's clear that the patient who needs to be intubated and ventilated needs to go to ICU. As I mentioned at the beginning of the talk, we really want to avoid early intubation or intubation until all other methods have failed. And so a patient who might look quite unwell may do okay in the ward on oxygen, some form of oxygen therapy. And so we don't have to commit to putting them into the intensive care unit immediately. And I think we do have to accept that there needs to be a great deal of fluidity in moving patients in and out of the ICU. And we may need to move some patients out of the ICU into palliative care if they're doing poorly, and so other patients can take their place. This clearly is a very big ethical consideration, and is difficult to think about because it's different to how we have done things before. But the world is different now, and we need to accept that, and we need to accept that we must change our practices. And so there may be patients who are too sick for intensive care, or who have not responded as well as we hoped to 24, 48 hours of treatment, who may need other options. And then the last consideration is palliative care. And it's really important that wherever we practice emergency care, we never withhold care, we never withdraw care, but we may provide a different type of care. And starting in the emergency department, I think it's really important to identify patients who are not candidates for escalation of care. And it may be patients who have advanced directives, who've decided that they don't want to be intubated or ventilated. Those are easy, but it may be harder when we see the 65-year-old patient who's previously been reasonably well, but has got severe COVID pneumonia with poor prognostic features. And we may just not have space in our ICUs for patients like that. And that's when really hard decisions need to be made. But I think it will help us and the patients and the families if we have a way where we can provide this palliative end-of-life care. So we're not consigning the patient to the corner of the emergency department to let them die, but we're providing care while they do it. In an environment where that's exactly what we are doing, is we are providing care, we're providing support, we're providing everything that is required. And I think that will help us sleep better at night when we know we are not withholding care, we are providing care, even though it may result in a death rather than a life. And I think certainly we need to think about this from the emergency department already, before the patients end up in different areas. And finally, just a couple of warnings to us. The whole study of how we think, metacognition, is around how our thinking biases us. not against particular patients, but particular circumstances. And we can break this down into two categories. The first is that, well, everyone is special, but not everyone is COVID. And although the isolation and the masks and so on is definitely going to reduce influenza and other infections, that a patient who presents acutely breathless, who's had contact with COVID patients, is not necessarily COVID. There might be a pulmonary embolism. It might be their previous heart failure causing problems. It might be bacterial pneumonia, although we haven't seen that for a while, but it definitely will be, we will see patients with that. Or it might be influenza. And that's actually a tough one, because some of the new evidence coming out shows that it's really hard to tell a bad influenza pneumonia from COVID pneumonia, even with CT scanning. So, and we teach this to our young emergency medicine doctors, is really important not to miss other things. So you can't assume that everyone is COVID, even when most people appear to be COVID. And that's why it's important to use appropriate imaging, to use appropriate lab tests and so on, so that we don't get caught with the patient who needs antibiotics, and in fact, we're giving them steroids for something else completely. So it's just a mind shift, always a second guessing of ourselves is if we make a presumptive diagnosis of COVID, we must consider that there may be other options. It's also really important, these are two pictures looking at, the top one is the PCR swab results and the antibody test at the bottom. And there are times, and if we look at the top here, we are going to miss patients. You know, we may have only a 70 or 80% pickup of patients with COVID at times. And so we have to remember that everything has to be treated with just a little bit of suspicion. The other thing, of course, is, let me just go back, is that what these graphs tell us is that not every patient that we think doesn't have COVID. And that's a really important consideration, because if we are putting patients into the green ward, we know that 3 out of every 10 patients that we do that actually have COVID. Or patients who come in with trauma may well have COVID as well. So we need to think that every patient has COVID until proven otherwise, and every COVID patient may have something else until proven otherwise. One of the big factors in emergency medicine is our pessimism. And it is important to have the mindset that we must make no mistakes. And the pessimism is, well, it's a patient with COVID, what else do they have? Or if it's a patient we don't think they have COVID, or maybe they do have COVID. And that mindset is one that's important to help us avoid making mistakes. So I'm not going to summarize the whole thing, but I hope I've touched on a couple of points to help you think. As I said, if you take nothing else home from this, please take home, don't intubate early, use the rotisserie with awake proning, and for the rest of it, there's a lot of reading, and if there's anything that's touched your interest, then I suggest you read up on that. One of the other questions that's come up is, which drug therapy is recommended for in-hospital ward patients? That's a really broad question. And if you can type one a little more specific in the next minute, then I'll try and answer it for you. But there should be no routine prescription. We know that patients who require oxygen and are with COVID need dexamethasone. We always need to give attention to the risk for thrombosis, and we would need to use either therapeutic dose or prophylactic dose of a low molecular weight heparin or something like that. And for the rest of it, we need to individualize it. All the vitamins and so on, I think only vitamin D has shown that the real, even though it's small, amount of benefit, but more information will still come out from this. So my time is up. Thank you. I hope it's been interesting. Thank you, Richard, for your comment. Keep an open mind. Things change quickly, and keep reading on this because that's the only way that we're all going to keep on top of it.
Thanks so much, Mike, and for another brilliant session, or for joining us for another brilliant session. I'll give it some time I see there were quite a few questions as you went along, but we'll open up the floor again if anyone wants to raise their hand and they can verbalize their question, or to type in their question into the chat bar as you've done thus far.
Precious Mandy, can you hear me?
I can, man. Go for it.
Sorry, I see a lot of people have logged in under my name. I wonder if people would mind going to just change their name so that we can get their CPD certificates correct. Otherwise, we're going to have problems. And then also just to make sure that if you logged in under somebody's name, the CPD certificate will come under that name. Unfortunately, it's nothing we can do.
Thanks, Mandy. Maybe just to check if anybody did log in and your name appeared as Mandy Token, maybe just double check and re-register to be safe, and we'll see if we can then pick it up and see what the issue is. But we can't see any errors on our side at the moment.
Gloria, thanks for your comment. I certainly will continue these talks. If COVID ever ends, we'll find something else to talk about. But we do have very successful conferences, and we'll continue these talks. Perhaps, Mike, we can think about doing one on sonar in COVID.
Yeah, we could.
There don't seem to be any more questions, huh?
Nothing that I can see, so maybe we can close it off there. Okay. I guess thank you again, everybody, for joining us. Thank you, Mike, for a brilliant talk, extremely informative, and we really appreciate your time, especially this late in the evening. So we'll close it there. Thank you all. Have a good evening. We'll see you tomorrow night. Mandy, can you remind me what the session is tomorrow night?
Yeah, tomorrow night is Professor Lucille Bloomberg, and the question says why this virus does what it does, but she's changed her talk, and she's going to talk just generally around COVID, testing, isolation. And Professor Bloomberg, Lucille Bloomberg from the NICD, is always a very good speaker and is going to take lots of questions. So we hope to see you tomorrow evening for that.
Perfect. Thanks, Mandy. Okay. Thank you, everybody. Have a good evening.
Right. Thank you.
Bye-bye, Mike.